Hey everyone, and thanks for joining us on the Deep Dive. Today we're tackling something that, well, probably touches all of our lives at some point. The aches, pains, and deeper workings of our bones, joints, and muscles. We've pulled together a whole stack of sources, everything from diagnostic guidelines to specific injury tests, and our mission for you is to, extract the most important nuggets of knowledge. Think of it as your shortcut to being truly well-informed about musculoskeletal conditions.
Yeah, and what's truly remarkable about the body support system is just how intricate the connections are. It's fascinating. Understanding these conditions isn't just about labeling a problem. It's really about recognizing the often subtle clues your body gives you and knowing when a particular action might be critical. So we're going to clarify some, complex distinctions and highlight those essential details you might not easily find in a quick search online, really equipping you with insights to better understand your own health.
Okay, let's unpack this then. We're starting with osteoporosis, often called a silent disease. But what does silent truly mean for your health? I think the critical insight here is that for many, the first real sign isn't like a twinge, it's a broken bone. That isn't just a medical fact. It feels like a powerful call to understand prevention and screening, before it's too late.
Exactly. It's characterized by a significant loss of bone mass and a weakening of the bone tissue itself. And its precursor, osteopenia, means you have lower bone density than normal, but it hasn't quite reached the threshold for full osteoporosis yet.
Right. So how do doctors actually pinpoint it? How do they know for sure?
The definitive diagnosis is made with a DEXA scan, that's dual energy X-ray absorbed geometry. You can think of it like it's osteoporosis, signaling significantly weakened bone tissue. While a moderately low score points to osteopenia, it's all about measuring just how dense and strong your bones actually are.
That makes sense. So what can we actually do then to try and prevent this silent progression?
Prevention strategies are absolutely crucial. Weight-bearing exercise is right at the top of the list. We're talking about activities where you're working against gravity. So think walking, jogging, maybe lifting weights. Less impactful activities like swimming or, say, light cycling, while great for cardio, they just don't put the same kind of beneficial stress on your bones. Quitting smoking is also vital. And ensuring adequate intake of calcium and vitamin D. That's key. Sometimes a vitamin D supplement is needed because, dietary intake alone often isn't enough, especially as we age.
Okay. And when does medication enter the picture for this?
Medications are typically prescribed once there's a confirmed osteoporosis diagnosis. Makes sense. However, they might also be considered for osteopenia if someone has a high risk of fracture, and that risk is often assessed using a tool called FRAX, the Fracture Risk Assessment Tool. A common first-line class of drugs are bisphosphonates, and you'll often recognize them because their names end in dronate. These medications work by slowing down the natural process of bone breakdown.
Right, the dronates. And what's often overlooked but seems absolutely critical for these bisphosphonate medications is how you take them. There are specific instructions that really make all the difference for effectiveness and safety, right?
You're absolutely right. Patient education here is vital. They must be taken first thing in the morning with a full glass of plain water on an otherwise empty stomach. And here's the kicker. You need to remain completely upright, sitting or standing for at least 30 minutes afterward. This helps ensure the medication is properly absorbed and, importantly, reduces the risk of irritation to the esophagus.
Good to know. Any special scenarios or connections we should be aware of with osteoporosis?
Yes, actually. Here's a fascinating connection. Sometimes a medication for one condition can surprisingly benefit another. So if you're dealing with both osteoporosis and high blood pressure, certain blood pressure medications, like a thiazide diuretic, can actually be a win-win. They help control your blood pressure, sure, but they also seem to encourage your body's bone-building cells, those tiny architects called osteoblasts, to get to work, while also reducing calcium loss through urine. Pretty neat.
Huh, interesting. Okay, let's transition now. Let's talk about two common types of arthritis that sound similar but are, fundamentally very different. Osteoarthritis and rheumatoid arthritis. It can be confusing to tell them apart, I think.
Absolutely. Osteoarthritis, or OA, is what we often call a degenerative wear and tear disease. It develops gradually. The pain typically worsens with activity, but finds some relief with rest. That's a key point. Morning stiffness usually improves within about 30 minutes. And it tends to be asymmetrical, meaning it might affect one knee but not the other, for example. It also doesn't cause systemic symptoms like fever. It most commonly impacts joints that bear weight or are heavily used, like the spine, hips, hands, feet, and knees.
Okay, wear and tear. And how does rheumatoid arthritis, or RA, compare to that? Sounds different already.
Oh, RA is a very different beast entirely. It's a chronic autoimmune disease. That means your body's own immune system mistakenly attacks the lining of your joints, the synovium, causing significant inflammation. The pain from RA is often not relieved by rest, and that morning stiffness can last for well over an hour, sometimes much longer. A key differentiator is that RA is typically symmetrical, often affecting both hands or both wrists or both knees, for instance. And because it's a systemic disease, it can come with broader symptoms like fatigue, low-grade fever, or just a general feeling of being unwell, malaise.
That distinction between OA and RA is so crucial. Thinking about it from a patient's perspective, beyond the technical symptoms, what's maybe one of the biggest practical differences in how these conditions might impact daily life, especially when looking at something like their hands?
That's a really great question. Hand changes are definitely a key visual differentiator. In both OA and RA, you might see something called Bouchard's nodes. Those are bony enlargements at the middle finger joints, the PIP joints. But Heberden's nodes, which are at the finger joints closest to your fingertips, the DIP joints, those are specific to OA. I always tell people to remember the dip is in the den for Heberden's and DIP. It's a helpful mnemonic. RA, on the other hand, can lead to more severe deformities over time, things like swan neck or boutonniere deformities in the fingers, which can really affect functionality.
Okay, the dip is in the den. Got it. And how do diagnostic tests help distinguish them? What are doctors actually looking for in tests?
Right, diagnostics. For OA, blood tests that measure general inflammation like ESR and CRP usually come back normal. That's because the inflammation is mostly localized to the joint itself. X-rays, however, will often show pretty clear signs of joint space narrowing and maybe bone spurs, indicating that cartilage is wearing away. For OA, because it's a systemic inflammatory disease, those same blood markers, the ESR and CRP, will typically be elevated, often quite high. X-ray changes for RA, showing things like joint erosion, are usually only visible in more advanced stages of the disease.
So wrapping up OA versus RA, what does this all mean for how these two conditions are actually treated? The approaches must be different.
Very different. OA management focuses mainly on preserving joint function and reducing pain. So this includes non-pharmacological approaches like regular, low-impact exercise, walking or swimming are often great choices. And then pharmacological options. NSAIDs, non-steroidal anti-inflammatory drugs, are common. They can be topical, like a cream for specific joints, or oral for more widespread pain. For RA, though, the first-line treatment involves a powerful class of medications called disease-modifying antirheumatic drugs, or DMARDs. Unlike drugs that just manage pain, DMARDs actually work to slow down the underlying disease process itself and prevent further joint damage. Methotrexate is a very common one.
Methotrexate. And with that one, there's a serious patient alert we really need to highlight, correct?
Absolutely. Methotrexate is very effective, but it definitely comes with potential side effects that need careful management. It's associated with folate deficiency, which is why you almost always need a folate supplement when taking it. It can also potentially lead to bone marrow suppression and liver or kidney injury. So very careful monitoring with regular blood tests is absolutely crucial for anyone taking methotrexate.
Okay, really important. Moving on from that widespread inflammation, let's talk about a very specific, often intensely painful inflammatory arthritis, gout. This one can really hit like a lightning bolt, can it?
It truly can. Gout is caused by the deposition of monosodium urate crystals, tiny needle-like crystals in the joints. Most famously, it hits the great toe, a condition we call podagra. It causes sudden severe pain, along with redness, warmth, and significant swelling, usually in just a single joint at first.
How do doctors really confirm a gout diagnosis then? Especially since the symptoms, that intense pain and swelling, could sometimes mimic other things like an infection.
Yeah, that's key. The gold standard, the most confirmatory test, is actually a joint aspiration. A doctor uses a needle to withdraw a bit of fluid from the affected jaw, the synovial fluid, and then they examine that fluid under a special microscope, a polarized light microscope, looking for those specific urate crystals. What's really crucial to understand here, and often confusing, is that a serum uric acid level in your blood isn't always elevated during an acute flare. So relying solely on that blood test to make a diagnosis during a flare can be misleading. You might miss it.
Right, so you need to see the crystals. Okay, so once it's confirmed, what are the strategies? How do you treat an acute flare versus trying to prevent future attacks?
For acute flares, the goal is rapid pain relief. This is typically done with potent NSAIDs like indomethacin, or sometimes oral or injected steroids like prednisone. Colchicine is another older option, but it needs to be started very early in the flare and can cause significant gastrointestinal side effects like diarrhea, so it's used a bit more cautiously now. For chronic management and prevention, the main strategy is to lower uric acid levels in the body to prevent crystals from forming in the first place. Allopurinol is the most common medication used for this.
Allopurinol. And a quick but important alert about starting that one.
Yes, very important. You should not typically start allopurinol during an acute gout flare. There's a concern it might actually prolong or worsen the flare initially. However, if a patient is already taking allopurinol when a flare hits, they should absolutely continue taking it. Don't stop. It's also worth noting that allopurinol can, although rarely, cause bone marrow suppression, so some monitoring is usually advised, especially early on.
Good to know. And any key lifestyle modifications that can help manage gout long term?
Definitely. Lifestyle plays a role. A low purine diet is generally recommended. Purines are substances that break down into uric acid, so this means reducing foods like red meat, organ meats like liver, and certain types of seafood. Avoiding alcohol, especially beer, is also quite important as it can trigger flares. And here's another medication interaction to flag. If you have both gout and hypertension, it's generally advised to avoid thiazide diuretics for blood pressure, if possible. They can sometimes increase uric acid levels and potentially trigger gout flares.
Okay, that makes sense. Let's transition now to fibromyalgia. This is a chronic pain disorder, but it seems characterized by much more than just physical discomfort.
Yeah, it's a really complex condition. It involves widespread musculoskeletal pain, often felt in specific tender point areas on the body. But it's also typically accompanied by persistent fatigue, often quite debilitating fatigue, and significant sleep disturbances. Many patients also report cognitive difficulties, things like trouble concentrating or memory issues, which is sometimes referred to as fibrofog. Unlike the inflammatory conditions like RA or gout we've discussed, there's no peripheral inflammation or obvious muscle damage in fibromyalgia. It's thought to involve abnormal pain processing within the central nervous system itself, like the volume knob for pain is turned up too high.
Wow, that sounds incredibly challenging to live with. Given how complex it is, what's often the first line of defense, or maybe the most impactful treatment approach to start with?
Lifestyle modifications are often considered the first and really the most foundational line of defense. Things like regular physical activity, even gentle exercise like walking, swimming, or yoga have documented benefits. It can help improve mobility, mood, sleep, and even overall pain levels. It's about finding what works for each individual and starting slowly. Stress management techniques are also key.
And for medications, are there any particular categories or perhaps an easy way to remember the main approaches that people should be aware of?
Yes, when it comes to medications specifically approved for or commonly used in fibromyalgia, a helpful mnemonic that's sometimes used is CELF to treat yourself.
Okay.
That stands for Cymbalta, which is duloxetine, Elavil, which is amitriptyline, Lyrica, which is pregabalin, or Flexeril, which is cyclobenzaprine. These medications work on different neurotransmitter pathways to help manage the widespread pain, fatigue, and sleep issues associated with fibromyalgia. They aren't cures, but they can help manage symptoms for many.
CELF. Helpful. Okay, so we've discussed these broader systemic conditions, but sometimes, like we said, it's a specific joint or area causing all the trouble. Let's shift our focus now and maybe zero in on some common localized musculoskeletal issues. How about we start up with the shoulder?
Sounds good. For issues like rotator cuff tears, which are pretty common, clinicians use specific physical exam tests. Two key ones are the drop arm test, where a patient tries to slowly lower their arm from an elevated position, but if the cuff is torn, it might drop suddenly. And the Job test, sometimes called the empty can test. This one specifically assesses the supraspinatus muscle, a common site for tears, checking for pain or weakness when downward pressure is applied. These tests help pinpoint the problem.
Okay, moving down the arm to the wrist, what about that really common complaint of numbness and tingling, carpal tunnel syndrome?
Right, carpal tunnel. It affects the median nerve, which runs through a narrow passageway in your wrist, the carpal tunnel. When that nerve gets compressed, often from swelling or repetitive motions, it causes numbness, tingling, and sometimes pain. Typically, this is felt in the thumb, index finger, middle finger, and about half of the ring finger. Clinicians use tests like Phelan's sign, where you press the backs of your hands together, flexing the wrists, and Tinel's sign, which involves tapping over the nerve pathway inside the wrist. Both tests can reproduce those classic symptoms if the nerve is irritated. Treatment usually starts conservative, avoiding repetitive movements, using wrist splints, especially at night, and sometimes anti-inflammatories.
What about that common type of elbow pain, often called tennis elbow? Is it just tennis players?
Not at all. That's epicondylitis. If the pain is on the outer aspect of your elbow, the lateral side, that's lateral epicondylitis or tennis elbow. If it's on the inner aspect, the medial side, that's medial epicondylitis or golfer's elbow. Despite the names, it's often due to overuse or repetitive strain of the forearm muscles, think gripping, lifting, even prolonged typing. Initial treatment is usually focused on rest, ice, anti-inflammatories, and sometimes using compression braces or straps to support the area and reduce strain on the tendons.
Okay, now let's turn to a wrist injury. That sounds like it can be surprisingly tricky. It carries a big buyer beware sign for diagnosis, the scaphoid fracture.
Oh, the scaphoid fracture. Yes, this one is a real potential pitfall in diagnosis. It's a fracture of a small bone in your wrist, right near the base of your thumb. It often happens after a fall onto an outstretched hand, a very common mechanism of injury. The key clinical sign, the thing to really look for, is tenderness when you press into what's called the anatomical snuff box. That's that little triangular hollow you can see at the base of your thumb when you extend it fully. Now here's the critical insight, the really important part. This fracture may not show up on an initial x-ray. The x-ray can look completely normal, especially right after the injury. But if someone has tenderness in that anatomical snuff box after a relevant injury, you must treat it as a fracture anyway, usually with immobilization like a thumb spica cast or splint. Immediate orthopedic referral is necessary. Why? Because the scaphoid bone has a very precarious blood supply, making it prone to not healing properly, a condition called a vascular necrosis, which can lead to long-term wrist problems if missed. So you trust the clinical exam, that snuff box tenderness, even if the initial x-ray is negative. It's crucial.
Wow, that's a really important clinical pearl. Trust the snuff box. Okay, what about pain right at the base of the thumb, maybe more towards the wrist side?
Ah, that might be de Quervain's tenosynovitis. It's inflammation of the tendons, specifically the sheath surrounding them, on the thumb side of your wrist. It causes pain, tenderness, and sometimes a weak grip, often worsened by grasping or twisting motions. It's diagnosed clinically, often using the Finkelstein test, where you make a fist with your thumb tucked inside and then bend your wrist towards your little finger. If that causes sharp pain along the thumb side of the wrist, it's suggestive of de Quervain's.
Okay. And finally, for the upper extremity, let's look at olecranon bursitis. That's sometimes alarming goose egg swelling right at the point of the elbow.
Yes, olecranon bursitis is inflammation of the bursa, that fluid-filled sac that normally cushions the bony tip of your elbow, the olecranon process. It can get inflamed from trauma, like banging your elbow, or from prolonged pressure, like leaning on it a lot. It causes visible swelling, sometimes quite dramatic, and possibly some limited range of motion, though often pain is mild unless it's infected. The really important distinction to make here is between non-septic bursitis, which is just inflammation, and septic bursitis, which means the bursa is infected with bacteria. You should suspect septic bursitis if there's significant redness, warmth, increased tenderness, or if the person has a fever or feels unwell systemically. Non-septic is usually treated conservatively with rest, ice, compression, and maybe NSAIDs. Septic bursitis, however, is a much more serious issue. It requires prompt medical attention, usually involving aspiration of the fluid to identify the bacteria, and treatment with antibiotics. You don't want to miss an infection.
Absolutely.
Yeah.
Okay, great overview of the upper body spots. Now let's shift focus downwards to the backbone of our support system, literally the spine and then the lower body, starting with common nerve pain originating in the back.
Right. When we talk about nerve pain radiating from the back, sciatica, also known technically as lumbar radiculopathy, is probably the most classic example. It's caused by compression or irritation of a nerve root in your lower spine, the lumbar spine. Most commonly, it affects the L5 or S1 nerve roots, which contribute to the large sciatic nerve that runs down the back of your leg. This causes pain, numbness, or tingling that often radiates down the buttock and leg, sometimes all the way to the foot. It's often evaluated clinically with tests like the straight leg raise test, where passively lifting the patient's straight leg while they're lying down reproduces their radiating leg pain.
Okay, sciatica. How does that compare to spinal stenosis? That also sounds like it involves nerve pressure and can cause leg pain.
Yes, spinal stenosis also involves nerve pressure, but the mechanism is slightly different. It involves a narrowing of the spinal canal itself, the space where the spinal cord and nerve roots travel. This narrowing, often due to age-related changes like arthritis or thickened ligaments, can squeeze the nerves, causing pain, numbness, or weakness, typically in both legs. A key differentiating feature, often a classic symptom of spinal stenosis, is that the pain is characteristically relieved by sitting down or leaning forward, like leaning on a shopping cart. Why? Because that forward flexed posture actually opens up the spinal canal slightly, temporarily relieving the pressure on the nerves. We call this the shopping cart sign. With sciatica from a disc herniation, leaning forward might actually worsen the pain sometimes.
The shopping cart sign. That's a helpful visual. Okay, what about ankylosing spondylitis? That sounds quite serious too.
Ankylosing spondylitis, or AS, is another chronic autoimmune disease. Like RA, it's systemic, but its primary target is the spine, particularly the sacroiliac joints, where the spine connects to the pelvis. It causes inflammation in the spinal joints and ligaments. Over a long time, this chronic inflammation can lead to the gradual fusion of vertebrae. Literally, the bones of the spine can fuse together, causing stiffness and loss of flexibility. On an X-ray, in advanced stages, this can give the spine an appearance sometimes described as a bamboo spine because it looks like one continuous column. It's a progressive condition that typically starts in young adulthood and requires ongoing management, usually by a rheumatologist.
Bamboo spine.
Wow.
Okay, we've covered many conditions, some quite common, some less so. But this next one is absolutely critical. It's a critical clinical alert. This is a true medical emergency, so everyone, please pay close attention here.
Absolutely. We cannot stress this enough. Cauda Equina Syndrome is a rare but extremely severe neurological condition. It's caused by severe compression of the bundle of nerve roots at the very bottom end of the spinal canal, below where the spinal cord actually ends. This bundle is called the Cauda Equina, which means horse's tail in Latin, because that's what it looks like. Key symptoms to watch for include severe low back pain, often sudden onset, new or worsening weakness in the lower extremities, maybe difficulty walking. Crucially, what we call saddle anesthesia, that's numbness or altered sensation in the areas that would touch a saddle if you were riding a horse. The buttocks, inner thighs, and perineum. And perhaps the most critical red flag, new onset of bowel or bladder dysfunction. This could be incontinence, loss of control, or retention, inability to go.
That sounds incredibly urgent and scary. What are some of the biggest challenges maybe in getting patients with suspected Cauda Equina syndrome diagnosed quickly? And maybe what can listeners do to advocate effectively for immediate attention if they or someone they know experience these symptoms?
The biggest challenge is probably its rarity, combined with the fact that some early symptoms, like severe back pain, are unfortunately very common and can be caused by many less serious things. But the key is recognizing that specific constellation of red flag symptoms together. The severe pain PLVUS, the leg weakness PLSMS, most importantly, that saddle anesthesia or the new bowel bladder changes. If you or someone you know experiences any combination of these red flag symptoms, especially the saddle numbness or bladder bowel issues, you must treat it as a surgical emergency. Go immediately to the emergency department. Don't wait. When you get there, you need to clearly and calmly articulate these specific symptoms to the medical staff, emphasizing their new onset. Say the words saddle anesthesia or loss of bladder control if that's what's happening. Prompt diagnosis, usually with an urgent MRI scan and subsequent surgical decompression if confirmed, are absolutely necessary to prevent potentially permanent paralysis or irreversible loss of bowel and bladder function. Time is critical.
Okay, message received loud and clear. Critical alert acknowledged. Let's pivot now carefully to common knee injuries. What are some of the key tests doctors use when they suspect something's wrong inside the knee?
For the knee, there are several specific tests. The McMurray test is often used to evaluate the meniscus. Those are the C-shaped cartilage pads that act as shock absorbers between your thigh bone and shin bone. A positive McMurray test involves a painful click or pop during a specific manipulation of the knee. And the Lachman test is widely considered the most sensitive and best clinical test for assessing the integrity of the ACL, the anterior cruciate ligament, which is crucial for knee stability.
Okay, Lachman for ACL, McMurray for meniscus. What are the classic signs someone might actually experience if they've, say, torn their ACL or damaged their meniscus? How does it feel?
Right. The patient's story is really important. For an ACL injury, people often describe hearing or feeling a distinct popping sensation right at the moment the injury occurs, maybe during a pivot or landing awkwardly. This is typically followed by rapid and significant swelling of the knee, usually developing within just an hour or two, and often a feeling of instability, like the knee might give way. Meniscal injuries, on the other hand, might not have such a dramatic initial event. They're often characterized more by persistent mechanical symptoms, like a feeling of the knee locking up, catching, or being unable to fully straighten or bend. Swelling with a meniscal tear typically develops more slowly, maybe over several hours or the next day, and might be less pronounced than with an ACL tear.
That's a helpful distinction, the pop and rapid swelling versus the locking and slower swelling. What about the ligaments on the sides of the knee? The collateral ligaments?
Good question. Those provide sideways stability. The valgus stress test assesses the MCL, the medial collateral ligament, which is on the inside of your knee. The examiner applies an outward force to the lower leg, and the varus stress test assesses the LCL, the lateral collateral ligament, which is on the outside of your knee. The examiner applies an inward force. Laxity or pain during these specific stress tests helps determine if those side-stabilizing ligaments have been injured, often from a direct blow to the side of the knee.
Okay. Now let's quickly clarify something that often gets confused in everyday conversation. The difference between sprains and strains. They sound similar, but they're different tissues, right?
That's a great point. They sound so similar, but yes, they involve different structures. Sprains involve damage to ligaments. Ligaments are the tough, fibrous bands that connect bone to bone, providing stability to joints. Sprains are most common in the ankles, but can happen in knees, wrists, etc. Strains, on the other hand, affect muscles or tendons. Tendons are the cords that connect muscle to bone. An easy way to remember the difference is strain has a T for tendon and muscle. Both sprains and strains are typically graded on a scale from 1 to 3 based on severity. Grade 1 is a mild overstretching, grade 2 is a partial tear, and grade 3 is a complete tear of the ligament or tendon muscle unit.
Strain has a T for tendon. Okay, got it. So what's the typical standard treatment for these, assuming it's not a complete tear?
For most grade 1 and grade 2 sprains and strains, the good old RICE-E method is the mainstay of initial treatment. RICE stands for rest, ice, compression, and elevation. Rest avoids further injury. Ice helps reduce pain and swelling, usually 15-20 minutes at a time, several times a day. Compression with an elastic bandage helps minimize swelling. And elevation, keeping the injured part above heart level, also helps reduce swelling. This approach helps manage the acute symptoms and allows the body's natural healing process to begin. Grade 3 injuries, because they involve a complete tear, typically require an orthopedic referral, as they might need casting, bracing, or even surgical repair depending on the location and the patient's activity level.
Nice. Simple but effective.
Yeah.
Okay, fine. Let's round out our anatomical tour with some common foot conditions that can really impact daily life and activity.
Absolutely. Foot problems are incredibly common. Let's touch on a few. Hallux valgus is the medical term for what most people call a bunion. It's a deformity of the big toe joint, where the big toe starts to angle inward towards the other toes, causing a bony bump on the side of the foot. Treatment often starts with wider shoes, padded inserts or orthotics to relieve pressure, and NSAIDs for pain. Surgery is an option for severe cases. Then there's plantar fasciitis, a very, very common cause of heel pain, especially prevalent in runners or people who are on their feet a lot. It's inflammation of the plantar fascia, a thick band of tissue on the bottom of your foot. The classic symptom is sharp pain in the heel, usually worse with those first few steps out of bed in the morning or after a period of rest. And finally, Morton's neuroma. This is an interdigital neuroma, essentially a thickening of the tissue around a nerve between your toes, most commonly between the third and fourth toes. It causes burning pain, numbness, or tingling in the ball of the foot or toes, often described as feeling like you're walking on a pebble or have a fold in your sock. It's often associated with wearing tight or high-heeled shoes.
Bunions, plantar fasciitis, Morton's neuroma. Okay, got it. So bringing this all together now, after covering this vast landscape of conditions, what does it all mean for managing musculoskeletal pain in general, especially when it comes to using medication? What's the overall philosophy?
Well, I think a really essential principle, especially in today's context, is to prioritize non-opioid options whenever possible for managing musculoskeletal pain. Medications like NSAIDs, both oral and topical, acetaminophen, and sometimes other adjuvant medications can be incredibly effective for many types of pain, and they generally carry fewer long-term risks compared to opioids. Physical therapy and lifestyle changes are also key parts of non-opioid management.
Okay, prioritize non-opioids. But what if opioids are deemed necessary, say for more severe acute pain, or maybe post-surgically for a short time? What's the approach then?
Right. There are definitely situations where opioids are appropriate and necessary for moderate to severe pain. But when they are used, a very careful risk-benefit assessment for that individual patient is crucial. What's become standard practice and often legally required in many places now is checking the state's Prescription Drug Monitoring Program, or PDMP, database before prescribing opioids. This database tracks controlled substance prescriptions and helps clinicians identify potential misuse, high dosages, or dangerous combinations, really aiming to improve patient safety. The overarching goal, if opioids are used, is always the lowest effective dose for the shortest possible duration needed to manage the acute pain. And alongside that, it's absolutely vital to educate patients. They need to understand how to take the medication properly, be aware of potential side effects like constipation or sedation, and crucially, understand the risks of dependence or addiction. Discussing the availability and use of naloxone, the opioid overdose reversal medication, is also becoming increasingly important, especially if there are any risk factors present. It's about maximizing benefit while minimizing harm.
Lowest effective dose, shortest duration, PDMP checks, patient education, naloxone awareness. Lots to consider there. Wow. We've really covered a vast and incredibly detailed landscape of musculoskeletal conditions today. From the, silent progression of osteoporosis all the way to the critical, urgent red flags of Cauda Equina Syndrome. This deep dive should hopefully arm you, our listeners, with a much clearer understanding of what your body might be telling you and, crucially, what specific things to look out for.
Yeah, I think this deep dive really highlights something important. It shows how understanding these specific details, the subtle differences between OA and RA, the key diagnostic clues like the anatomical snuff box or the shopping cart sign, the nuanced management principles for medications like bisphosphonates or methotrexate. Knowing these things can truly make a difference in how you approach your own well-being. It really empowers you to be a more informed participant in your own health journey, doesn't it?
It really does. Consider how understanding these very specific symptoms and diagnostic tests can empower you to ask more informed questions when you talk to your doctor, to advocate for yourself more effectively, or perhaps even spot something potentially critical for a friend or a family member down the line. We really hope this deep dive has given you a powerful shortcut to being well informed and maybe even sparked a little more curiosity about the incredible complex mechanics of the human body. Thanks for joining us.